The Autism Research Institute relies on the generosity of donors like you to make this webcast possible. If you enjoy this presentation, please consider making a donation. Thank you.
Now, before we get started, I'd like to introduce our speaker. Kelly Barnhill is the director of the Nutrition Clinic at the Johnson Center for Child Health and Development. She's a certified clinical nutritionist with over a decade of experience working with nutrition in children with autism and related disorders. At the Johnson Center, she directs a team of dietitians and nutritionists that has served more than 3,000 children through her practice. In addition to her clinical practice, Kelly also serves as the Johnson Center Clinical Care Director, overseeing management and implementation of multidisciplinary care across the practices within the organization. In 2008, Kelly accepted the position of Nutrition Coordinator for the Autism Research Institute. In this role, she designs and manages curriculum and training for nutrition practitioners each year, as well as providing direct training for parents.
Thank you so much for joining us this afternoon, this morning, this evening. I have a lot that I'd like to go through here with you in a short amount of time, so forgive me if I move too quickly. I try to include a lot of texts on my slides so that it's easy to follow along and you can take notes as I talk. I really have 4 areas that I want to talk with you about today. One, I want to look at what feeding behavior looks like in young children. I know that there's more information out there now than there has been on just what feeding issues look like in the general population and how parents are struggling with choosing the right foods and getting their children to accept them. And I want to take a look at that. I also want to look at specific feeding concerns for children with autism. I then want to look at an overview of medical, nutritional, and other concerns associated with poor, what we call professionally poor feeding behaviors. So there are many, many factors that play into a child's issues or concerns or refusal with food, and all of those need to be evaluated fully before you actually try to intervene and understand how to make things better if you're dealing with a child who has some fairly significant feeding concerns. And then I finally want to spend the most time, I hope, walking through when to seek professional help, what that professional help can look like, and what the strategies for success that you use in a clinic setting, what those look like in translation to the home environment. So what's our baseline here? Many of us believe that we are the only ones with children who are aversive to food, who don't like food on their plates, who don't like their food to touch, who don't like to try certain whole categories of food, so no protein, no green vegetables. But in fact, about 1/3 of parents report that their child under the age of 5 is a picky or selective eater. They also rank, in a recent pediatric poll, they also rank that feeding issues, feeding concerns, and worry about food is the second most unaddressed problem that they bring to their pediatrician, because this article was highlighting the fact that pediatricians aren't really well equipped to give advice on feeding and feeding techniques for kids in general. The number one unsatisfactorily addressed problem was colic or crying, unexplained crying in infants. Most recent research validates that about 25% of children in the general population have a selective eating bias. So all parents worry in these circumstances. If you are a child, if your child fits into one of these categories, we worry about these things. Is it going to affect his growth? Will he be too small? If he's not eating now, will he grow later? Is what happening right now going to affect his nutritional and health and medical status long term? Why is he doing this? What's the rationale behind this behavior? How do I fix it? Does he really have to eat fruits and vegetables, or can we do that a different way? What about those vitamins and minerals? Can he get them somewhere else? Do I need to cook 2 or even 3 meals a day in the evening just so he eats something? Many of our clients come in and say, well, I made this and he refused to eat it and would only have a peanut butter and jelly sandwich. So I made him that and then he refused to eat the peanut butter and jelly sandwich. And above all, is this normal? And what is normal behavior? Those are all our worries. And this is something that I like to think about that came out last year. There's a blog called mommyshorts.com, and she started running a feed on picky eaters. And it really humanizes this experience for those of us who have children who have difficulty eating, I think. And I think maybe you'll find many more of those on the web. But just remember that you are not alone, first. And second, really, I also want to emphasize and reiterate that when I talk to families and when I give presentations, one of those things that's interesting for me is that as parents and as adults, we are allowed to choose foods and we are allowed to have preferences and we are allowed to say, I love that salad, or that's a great smoothie. And we are allowed to say, I don't want to touch any beef, or I don't like that red meat. But in children, they're labeled as picky or selective or difficult eaters. So it's a very fine line for me that I walk, because I think that we need to allow our children the opportunity to define what their preferences are in a safe place while they are also having their nutritional needs met. And I think that's a balance. So it's one thing to say they're allowed to choose, and I don't ever want to label negatively choice when there are lots of options out there, but I also want to make sure that their nutritional needs are met. So let's talk about development of skills in early childhood. So what should a child who's developing along a typical trajectory be able to do by the age of 3? Most children by the age of 2.5 have developed the skills that they need to be independent eaters. So they can pick up their food, they can put their food to their mouth either with their fingers or a utensil. They can chew thoroughly so that there won't be an issue with choking, and they have swallowing ability. They have the ability to consume any appropriate solid food or beverage that is presented to them. So by appropriate, the caveat there for me is allergen friendly if you're avoiding allergies, if you have a child who has a restricted diet of any kind, if you have a child who has clearly been identified in a prior circumstance for having a need to restrict to something, that's how I define that. And what and when a child eats when they're in this window of toddlerhood, young childhood, it's largely determined by their tastes and their preferences, like I mentioned earlier. It's not determined by a lack of coordination in getting the food to their mouths or a lack of ability in chewing and swallowing. So what are our feeding expectations? We expect our kids to do so much in this window of time, and we still do for years after this, frankly, but in this window where they're building those physical skills of being able to chew and swallow and coordinate getting a spoon to their mouth or a fork to their mouth and getting something on that spoon or fork to begin with, we also expect them to figure out a lot of different things about foods. We expect them to figure out texture, because we don't really explain this. Kids are just expected to absorb this from their environment. So textures, smooth textures versus crunchy textures, flavors, things that are sweet, things that are salty, temperatures, like what food is hot, what food is best when served hot, what about cold foods, what about room temperature foods, and colors. So all of these things from a sensory perspective are thrown at our kids, and they're expected to figure all of this out without any overt instruction in that regard. We also expect them, and this is equally important, to figure out appropriate mealtime behaviors. And we do some teaching here, but we expect them to understand what it means to sit at a table with a family. We expect them to know what it means to be able to share food and share that cultural, environmental experience. And we also expect them, from a more biological perspective, to figure out an appreciation for timing of meals, figuring out what hunger actually feels like and what feeling full feels like. So that's an incredible amount of knowledge to absorb and assimilate and use appropriately in a very short window of time. So what is really appropriate? If I'd put appropriate in quotes if I could, because these are the things that define what is absolutely okay for a child in this window of time to be doing. And we all need to kind of understand this, I think, and have realistic expectations. So first thing, very young children are very distracted. They are so busy learning about everything in the environment around them and trying to figure out what's going on. They have to be taught to focus on certain things. And we have to respect that they can't be focused on that all the time. They are developing their individual preferences and becoming independent. And that's a big one, because I know many families that we work with say, I hear, yes, 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 I love this. No, I don't like that, for the very same food. And that's just also a way that a child can exert independence and control over their environment, and it's a healthy way as long as we're teaching that appropriately. Excuse me. At the same time, young children are cautious and wary of new things. You know, they are wondering about what's going to happen next, and food is no different, really. Many young children experience something called neophobia, which is a suspicion and fear of food in the environment. So what other factors are at play? Young children have a highly variable dietary intake. Again, likely biologically driven in some respect. Sometimes they are incredibly hungry. You have those windows of time where your 3-year-old gets up and eats and eats and eats for days and can eat a lot of food, and it just makes you wonder. And then 2 weeks later, not hungry at all through several meals as well. That is fairly appropriate behavior. Clearly food jags, which is something we'll talk about later, or food strikes are not. And you really need professional guidance to be able to understand where walking that line between expressing choice and doing something that's dangerous occurs. So we're also, and I mentioned this earlier, developing hunger and satiety recognition factors. So it's a work in process, not only for kids, but for us too, because it's that ability to decide, okay, yeah, I'm hungry now and I need to eat now, and okay, I should stop eating now. And that's something that people need to learn. The interesting part is when kids express this as a society, really, and we are as adults learning to back off on some of this, but as a society, we more often than not need to recognize that a child has the ability to say, okay, I'm full, and respect that rather than layering in any demands on food consumption there as well. So what kind of professional perspectives are out there? In looking at the research and looking at other people who are writing on feeding and feeding concerns, many pediatricians who are writing on this now claim that this evolutionary perspective, that being afraid of food and being afraid of new food is actually healthy and safe, that you want, it's an approach, a belief, a thought process that you want because it's a self-preservation skill that we value in other circumstances. We also know that science bears out that from an instinctive place, we have a desire for sweet and salty versus sour and bitter tastes. On the flip side of that, I would argue that if you introduce healthy foods that are sour, bitter, less sweet, less salty, at an early age, you can shape preferences and behavior in a healthy way. But I think the research pretty concretely says instinctively our preferences are otherwise. Also, many people and many writers out there looking at this from both a research and clinical perspective see picky eating as a natural and appropriate state of being for young children. And I think I've kind of given you the background on why that would be the case. So the takeaway for me here really is, number one, eating skills and patterns are learned, and we need to actively teach those to every child, whether it is in a clinical setting or in a home setting and in a family setting. Sometimes it takes patience to do that, It takes understanding and respect of that child and the process, and often it can take longer than expected because in addition to doing something to make progress moving forward, you are likely undoing a pattern of behavior that has been set. And last but not least, again, don't worry. The amount of emotional involvement that we all have around food is pretty significant, so setting aside the worry and the stress is helpful for each of us because we are not alone in any of this. And I think with some key strategies here that we'll go over later, we can be effective in giving you some tools, I hope, that will be helpful in your households. So in a general pediatric population, I mentioned this earlier, about 25% of kids have been diagnosed with a feeding problem. In kids with disabilities, it's documented that there are more feeding problems, which is probably not surprising. A survey completed about 5 years ago, which seems to be the most up-to-date option, is that about 90% of parents with a child with ASD indicate a report a feeding problem. Why does this matter in the autism population in general? Currently, the research is somewhat mixed. There's more coming out every day. There's some great work that's recently been published out of the Marcus Center in Atlanta. But ultimately, two things. One, we all need to pay better attention and take care of ourselves nutritionally. But children with autism face an increased risk of nutritional deficiency and concerns because there are GI complaints, there are absorption, digestion, concerns which can compound nutrient availability for them and also factor into any potential nutritional deficiencies. So when do you need to be concerned? In general, as a gut feeling, parents know, okay, this is a problem, this could be a problem, oh yeah, this is a really big problem. But hopefully I can give you some pretty specific outlined information on, okay, which boxes do you check and where does that lead you? Which path does that give you? So a picky eater is someone who has food preferences. They accept 30 or fewer foods. They have narrowed food choices just because they don't like some things, because they've been taught not to like some things. They've been taught that if they refuse something, no one's going to force them to do something, that if they accept one particular type of food, they will get lots of praise. Something in the environment may have, and behavior in the environment may have contributed to their preference or rejection of certain foods, all of those things. They could have a craving for a particular food that contributes to a food jag. So I only want to eat potato chips for the next week. And they may do that. Another issue that comes up is just the tip of the iceberg, really, of any potential GI problems, and that is they could be self-selecting or avoiding foods to avoid a reflux concern. So those are really factors, and that's where you would say, if you go through a workup and just if you check the boxes and you're here, this is something we would say to you, keep an eye on that. Just watch that behavior, keep introducing new foods, recognize that it takes a lot of introductions of a lot of different things for a child to accept it. On average, it takes about 15 times for a child to want to try a food and accept it from the first introduction. So what is a problem eater? Now we're going down this continuum of eating concerns, and problem eaters, defined in the literature, are children who eat fewer than 20 foods. Often they have complete food refusal, either short-term complete food refusal, or they will go through periods of refusing foods that they once loved, or refusing entire types of foods. They may exhibit vomiting or gagging or choking at times. They could start to show some growth status concerns. So these are the kids who tracked nicely along their growth chart, and then suddenly they start declining somewhat over a 6-month to a year time frame. They have a phobic reaction to new foods, so that neophobia that I mentioned is somewhat out of control. These are the kids who cannot sit at a table while someone else has an apple, for example, without being upset if the apple is their trigger. This is a little bit more of a red flag, and we would say, okay, perhaps we need to create a plan for intervention in the home. Once we do a nutritional workup and we see, okay, are there any deficiencies there? How do we target specific foods to introduce? What's our game plan for getting acceptance and helping the child and the family do that? What's a resistant eater? A resistant eater is a child who consumes fewer than 15 foods. They are the extreme end of this kind of continuum of eaters, as we've talked about. They have severe food aversions. These are children who are sincerely afraid of food. They are children who perhaps have medical impairments. They have anxiety and tantrums when they are around food, in the presence of another food, much less having it on their plate or touching their lips. They may have an autism diagnosis or a similar developmental delay diagnosis. This comes from the research of Lori Ernstberger and Tanya Hansen, and they have kind of nicely categorized intervention opportunities for children who are classified as resistant eaters. So in children with autism, what are the specific concerns here? Children with autism have an increased potential for medical concerns. That would include, from a GI perspective, that would include reflux, which I mentioned earlier, eosinophilic esophagitis, which is an allergic inflammatory response that can actually occur anywhere in the GI tract. It's just an eosinophilic infiltration of cells in the lining of the tissue. A gastritis, colitis, small bowel inflammation, some form of physiological abnormality, which is rare but something that we have seen in children that we serve. Symptoms, if there's a medical concern here, would be vomiting, gagging, coughing. A child who complains of a sore throat, if the child is nonverbal, they're often either hitting their throat or hitting their chest, hitting their stomach. Diarrhea or constipation, or alternating diarrhea and constipation, which is also another big thing that we see, and any sign of skin involvement. So eczema or asthma, hives, other things that you might see are rashes that appear, or any other immunological concern that might be an IgE-mediated response, but not something that's as severe as anaphylaxis. Those things are medical concerns that you would want to have full information and full knowledge of before you ever did anything in terms of intervening to increase a child's and diversify a child's diet. So what kind of nutritional concerns are there? Well, there are lots of nutritional concerns, frankly, that we see. There can be macronutrient concerns, though that's not so often. So most kids that we see get a fair amount of protein. If they are a child who is in complete protein refusal, we know where to start immediately with amino acid and protein support there. But in general, the children that we see have a fairly good macronutrient distribution of proteins, fats, and carbohydrates. They may be heavy on the carbohydrate intake. The things that we are concerned about and that we see deficiencies in from a nutritional perspective fairly frequently are micronutrients and vitamins and minerals. And specifically, we see children who are deficient in vitamin D, which from a dietary perspective has one source, milk, cow's milk, and also primary one source, I should say. Also zinc deficiency, which seems to be one of the largest deficiencies that we see when we do workups here, which is the one that I chose to highlight for you because it creates a zinc deficiency can and often does create so many other concerns in terms of feeding and feeding behaviors as well. So it can decrease a child's appetite. If you're zinc deficient, you just don't have a need or a will to eat. It causes changes in taste bud function, so nothing really tastes good. There's an impaired sense of taste. It can be problematic with motor planning issues and processing issues and muscle tone issues. And one of the things that we often see is pica. And that pica can be a function primarily of zinc deficiency or also iron deficiency. In terms of physical concerns, we really feel strongly that you also need occupational therapy, physical therapy, or speech therapy, or some combination thereof evaluation, a full evaluation as well, to be able to accurately plan forward in creating change for your child. So if there are oral motor concerns, does the child have the ability to consume a variety of foods and fluids, or is the child self-limiting to foods that he can manage and handle? Are there sensory concerns involved? Many of the children that we work with have aversions and fears of certain smells and textures and flavors and temperatures, as I mentioned earlier, and those drive food choices. And finally, behavioral concerns can also be looked at in this. Typically, in our model, that's completed by a behavioral therapist, a BCBA. And one thing that you want to look at and evaluate carefully is, have the caregivers reinforced the negative behavior on the part of the child, and is that what is driving some of the concerns? And do we need to help create a program and create opportunities for that child to succeed and change that behavior? So the sum of all of these factors weighing in has a significant impact on the children that we see. They can be more passive, they can be withdrawn, they can be anxious, they're stressed out, they can be distracted, despondent, tears, tantrums, anxiety, aggressive and self-injurious behaviors, both at meal times and at others. There can be potential medical involvement. Some children that we work with self-limit foods until the point of complete food refusal or complete food group refusal, and you then start talking about, okay, we need to start supporting that child with a formula that's nutritionally complete, or we might need to talk about a tube if they refuse to swallow, or we need to talk about other forms of enteral nutrition so that we know their needs are met. There are ultimately significant nutrition concerns. Malnutrition concerns can continue to develop. Failure to thrive can become a real possibility even for children who were born and placed strongly and solidly in the 50th to 75th percentile. That poor growth status can be evidenced short-term over time, but the most clear by lowered weight, but the most clear glimpse that we get about longer-term malnutrition and feeding concerns is actually height change as well, so a decrease in growth over time in height. It can also, in addition, create an enormous amount of stress and pressure for the family in what is already an terribly stressful time. So there are missed meals, there are opportunities for social engagement that families who have very few opportunities for that miss out on. There's a chance for that child or their siblings to bond with each other and with extended family members. It disrupts a family schedule. Suddenly parents are building, not one, but two, but three meals, and people are eating at different times and in different places so that the chaos and stress is kept to a minimum. So what do you do about all of this? I walked you very quickly through a high-level look at what to do in terms of building a plan and who the people weighing in on that from a professional perspective would be. So you really need a solid pediatrician and GI specialist involved if you have any indication at all that your child may have gastrointestinal concerns. You need occupational therapists, speech therapists, physical therapists that you trust, weighing in with a full, extensive, complete OT, PT, ST evaluation for oral motor skills, and others to be able to fine motor skills, gross motor skills, to be able to accurately understand what reasonable goals are for your child. You need a dietitian or nutritionist who can fully evaluate everything that the child is eating and also make recommendations for what the child should eat in the future. Really, that looks like a full evaluation by the GI specialist, as I mentioned, to rule out each of these diagnoses, a nutrition evaluation that will be both physical and also a 3-day diet diary analysis to look for any nutrient intake deficiencies that could be mitigated fairly easily with a vitamin, for example. That OT-PTSD evaluation I mentioned, and finally a behavioral evaluation, which I touched on briefly, looking at all of the behaviors impacting the success of that feeding program. So what does that look like from a behavioral perspective? These are some of the questions, and I lay them out here. There are many others, but these are some of the questions that, in looking at behavior and environmental factors that might affect a child's eating, would be useful. And I put this here because these are the high-level questions that, as we talk later about things that you can implement in your own home, these are things that you can roll in and think about in the scope of, okay, I want to go home and make 3 changes at the dinner table tonight. And this is just a set of questions to help you get to what you might want to do. So as the parent or caregiver, take a look carefully at the stress and the demands and the anxiety that might be driving the interaction with the child. Many parents, many mothers in particular, are so worried, rightly so, about enough calories going in for their child that they are very stressed out and anxious, and the child knows that. And there's a behavioral reaction to that, or a choice based on the child's reaction to that. So examine your family patterns. How are your meals handled? What does that look like? What do you want it to look like? And then make a plan from where we are now to what you hope for. And do you as parents model good behavior? So is your child seeing you eat, and are you eating the things that you are expecting your child to eat? Then take a look at what you're using. So what types of bowls, plates, cups, utensils are you using? Are they things, I know as adults we don't think this is that big a deal, but in the clinic setting and both in my home, I have children who love to choose what they're using, and as long as they're appropriate, get them involved, and that can be really reinforcing to have them have a voice and a choice in choosing that equipment. Do they have a sippy cup preference? Do they have an open glass preference? Whatever you're using, give the child control and choice in that, and that will also help you in the long run. What about the environment in general? Are there any sensory concerns that we need to deal with? What kind of lights are in the room that you're expecting the child to eat in? Is it something that is a known problem for that child in a different environment? Are there sounds? Do you have a TV on in the background? Is there a radio? Or are there distractions that are auditory that the child cannot focus on what you're asking of him? Is there too much activity in the background? All of those things can help you carefully evaluate and make choices for change in your home meals to improve your child's feeding success. So when you make your master plan, it can really go in 2 directions, but you're going to start with the same information. So include input from you, the family, and the caregivers. All the medical professionals that we've talked about, the nutritionists, the speech, physical, and occupational therapists, and the behavioral therapists. That's the data that's going to help you make a choice about what to do next. And what to do next, really, as a parent, you need to look at that data that you've gathered, and you can choose a professional care plan. So if something comes up medically, if something comes up nutritionally, if there are problems behaviorally that are so significant, you may need to enter a feeding program that can be primarily, we have seen good success with very short-term intensive intervention within our walls and others. There are also programs that meet on an ongoing basis, but I haven't seen much data out there, and I've supporting that efficacy of a food approach on a long-term basis. And just know that a professional path would include making sure that all those underlying needs that we've talked about have been addressed in a multidisciplinary environment, going towards a short-term clinical intervention, which would be a week perhaps. The one that we run here is a 5-day session with very high success rates with appropriate behavioral support for the child and the family. All contributing needs are addressed before we ever admit a child to the program, and parents get a lot of training when they leave so that they can be effective in the home environment when introducing new foods as well. So you can choose a path based on the medical recommendations that you have and your gut, really. If you feel like you need intervention that's more directed and clinical in nature, that's one path. The other path that you can use to augment or choose to do this first is creating success in the home, asking yourself these questions. So I gave you some questions initially about the environment. Now, here are some other things. Start making your lists. Who's feeding this child? Who's responsible for feeding? This is the first question that's going to give you clues to assist in moving forward, I think. Is the child refusing food when dad is feeding but eating when a mom is feeding? Is grandma successful? Is the babysitter the best one? Start tracking food intake and also caregiver involvement, I guess. So when does the child eat? Be very specific. So do you have a child who wakes up and is ravenous and will eat and eat and eat at 7:30 in the morning? Take note of that. Do you have a child who absolutely refuses food until lunchtime? We need to start determining patterns of hunger and satiety and have those help us drive what we do, because children are more likely to accept new and novel foods or be more willing to try new foods if they are hungry, not starving, but hungry and willing to eat. So what is the child eating exactly? Make a list of everything that your child enjoys, and also make a list of everything that you've tried to get your child to enjoy and have been unsuccessful in doing so. Where are you eating? Is the child eating in the same place? What does the environment look like? Is it an appropriate child-sized chair? If not, we need to start remedying some things in the environment. Is the child in the same room? Does the child get to eat with the family, or is the child isolated? And how successful have you been so far across caregivers in having a child accept this food? As you begin this process, remember that your child's feeding level may not equate to his chronological age, and this is totally okay. This is why you are seeking change, but you want to build from current skill set and not expect a child to go from 0 to 60 just like that. This is why we start with babies. We start with milk, and then purees, and then other foods. And you expand as acceptance improves, but set realistic expectations so everyone feels successful. So what are your targets for new food introduction? Answer all those questions, and then you start thinking about things. This is the checklist. Establish the ground rules before you start making change. So create a before meal routine. What does it look like before your child ever gets to the table? 15 minutes before the meal, set a bell. Okay, 15 minutes until dinner, and then 10, and then 5. Whatever that prompt has to be for the child to make it successful for your individual child, that's what it should look like. If your child doesn't like to transition out of something to the dinner table, start implementing something like that. Doesn't need to be, okay, we're going to go outside, we're going to play around, then we're going to have a bath, and then we're going to get into the dinner table. Whatever that routine needs to look like for your family, have a very, very clear image of what it should be in your mind and write it down so that you adhere to it. Other things, remember to choose appropriately sized portions, provide child-friendly meals. Do not become a short order cook. Do not get into the place where you are doing dinner and then peanut butter sandwich and then grilled cheese and then plain pasta. And I have families who do that pretty regularly, but do not start that or stop it if you have. And this is a plan to help you be able to do that. Change your menu frequently. Yes, we all like sameness, but we all also need to be able to accept new things and accept when things change, because it happens for all of us every day in our lives. We need to be able to deal with things when they're absolutely not the same. Also provide minimal distractions. So put your cell phone away, turn the TV off, turn the video off, no games around, etc. Then create a schedule. So you need an agenda that looks at meals and snacks and fluid consumption every day, every week, every month, and include goals for you and for your child. And post it and stick to it so that you want dad and babysitter and nanny and grandma to know exactly what the plan is and sign on. So what kind of foods do you want to offer? Really, you want a variety, but you want that variety based on representation of each food group, the child's flavor preferences, and the child's texture preferences. And you can start small in making change, and remember the rule that it takes a lot of reintroduction before you get success, and rejection 10 times in a row is totally okay. Keep your environment consistent. So make sure the kitchen and the table are clear. Any clean environment to work with is better. Offer very few distractions for your child and clear expectations of what you want the child to do for you. I want you to take 2 bites of this food. I'm going to put 1 raisin on your plate. I want you to eat that. I want you to put it in your mouth. Be very clear with what your expectations are. And anyone who comes in contact with your child during this window of time needs to know what the plan is. So if you're going and putting them in the nursery at the gym 1 hour a week or 1 hour a day, that caregiver needs to know, please do not give him a bag of goldfish here, because we are going home and he needs to have his meal there. Whatever information that you need to share with those in the community to help you and your child, do so. Then be creative. Make your food fun. Start writing things down and involving the child in the food. Use cookie cutters, build characters, go online and look. There are lots and lots and lots of options on everywhere now for making food fun for kids. Get videos and songs and books at the library about food. You can play games. There are toys. You can have a play kitchen. You can finger paint with food if you have a child who's somewhat aversive to things, particularly puddings and purees. Start there. Now back to the serious stuff. Manage that mealtime behavior that I mentioned. You can use a timer both before the meal and during the meal. That timer can signal it's time to come to the table, and it can also signal it's time to take a bite. If you need to use something that specific for your child, don't be afraid to do so. Other things that you need to remember are modeling, like we talked about. Allow the child to have fun while you're doing this. Don't allow grazing. So in addition to ruling out the snack bag of goldfish, also remember that grazing while you're trying to introduce new foods defeats the purpose, because if your child is not hungry when he comes to the table, he will not be willing to eat, much less eat something he doesn't want to. So how can you help your child be successful in this? Children love new foods when they get lots of praise and lots of support, particularly if there are other people listening to them get lots of praise and lots of support. We know this. Set a good example. Parents and sibling examples are key from the literature. Mothers' exposure to and acceptance of new foods is the key. Finally, create a comfortable environment. A relaxed environment, an environment where you as a parent are not stressed about that food, is key. Be consistent. Don't allow eating outside of your defined meal times, and this is another point I wanted to make. Water should be the liquid of choice. If you are currently allowing your child to drink juices or milks, Weaning away from those will wean away excess and unneeded calorie intake that doesn't have a lot of nutrient value and allow you to introduce more foods. So what are other strategies that you can use? Involve your child. Make meal plans. Your child can help you build from favorites. So one favorite meal, one new meal. And it can be a very simple exercise to start with and become more and more complex. Your child can help you make shopping lists, your child can help you write the shopping list, and your child can help you check the shopping list off at the store. You can choose favorite fruits and vegetables while you're shopping, and then your child can actually be involved in cooking, and there are several really good books out there now that talk about involving children under 5 in the kitchen and have very specific steps for doing so. You want to keep all those jobs skill level appropriate, no pressure, recognize it's going to be really messy, but it's worth it in the long run. You want one-step instructions to start, but you can teach across all of these different aspects of food, so setup and preparation, cooking and cleanup, and those are all things that your child can be involved in if you have the patience and wherewithal to do so. I mentioned earlier how you can introduce one new food for one preferred food and how you want to expand food offerings based on the child's preferences. So if you have a child who loves potato chips, those can become homemade potato chips, for example, or they can become store-bought root vegetable chips, which are potato chips and other root vegetables. They can become homemade carrot curls or parsnip chips, or lots of options out there to expand nutrient density and things that your child currently likes. Fast food French fries, we see many kids who have a particular fast food fry preference. They can become homemade white potato fries and then move on to sweet potato fries or other root vegetable fries or even baked butternut squash sticks. All of those things start from the same preference and the same theory, and many kids, when you move them along in that food chaining way, will accept them. Know that it's not going to be easy. Don't get discouraged. Set realistic and appropriate goals for everyone involved. Recognize that it will get worse before it gets better. From a behavioral perspective, that's known as your extinction burst, but if you're consistent, the tantrums and the cryings and the outbursts will diminish ultimately, and keep trying and write down as much as you can so that you learn from what you did yesterday and can apply it today. Most of all, remember, you aren't alone in this process, and there are more and more people out there who can help with it every day. So thank you so much for your time, and I'll take your questions.
Okay, great, Kelly. Thank you so much. We've got a lot of questions. Some questions were typed in during the talk, and those are here, but I've also got some that we had emailed to us, so I'll try to get to some of those as well.
Okay.
My 6-year-old grandson eliminated most of the things he will eat, and sometimes he will not eat at all until dinner time, when he will eat only the same thing every night. He never ate a wide variety. He does have sensory issues. I'm not sure how to help him. He has had a few days during the summer he'll go all day without eating. What might cause this, and what might we do next?
I think my recommendations would be to look at what might be going on medically. So talk with a pediatrician and bring it to the pediatrician's attention immediately if that hasn't happened. I'm assuming or hoping that if it's a child with sensory issues, there's an OT involved, and that OT could do a full evaluation. But what might need to happen is a referral for a full medical workup, because it could, one, be a behavioral preference driving this change, but if it's severe and significant where you're looking at days without eating and limiting foods into one of those categories that I mentioned, I think it's time that you get some professional eyes in there to see if there's anything else contributing to what's going on to influencing those choices.
Okay, great. Okay, the next one is, this person is asking about pica. Could you tell us more about it, and what causes it and what it looks like?
Yes. Pica is, in the literature, pica is noted as a craving for and an eating of non-food items. It's a very general category. In the children that we work with and that we see, it is a pretty broad behavior. So we see children who come in and will lick metal door frames and doorknobs, eat dirt and rocks. There's a craving for things that very clearly they offer no nutrient value. What we also know is that mineral deficiencies, particularly iron, can cause pica. And it's and iron is involved because, and I don't know if everyone knows this or not, but we track iron in pregnancy in infants because mothers, one thing that we asked, OBs ask a lot is, do you have a craving for ice? And that's pica. That's chewing ice is one sign of pica and iron deficiency. So iron deficiency can drive it. Zinc deficiency can also drive it. And in general, it can be resolved and remediated pretty quickly and the behavior goes away if it's a deficiency and you just give a mineral supplement.
Okay, so this parent is asking, I have an older child. My child is 13. So what do you do to expand at that age, especially when he only eats a fixed list of permitted items, although he likes to eat many things to which he is intolerant or allergic?
So we get that question a lot, and the answer is really use the same philosophy and the same approach. So that child needs to be involved in creating it because he's older and because he has a very clear role and preference, and clearly he's making choices for foods that he knows he's intolerant to. He needs to be involved in making the plan of action there and creating the reinforcers. So whether it is, okay, we're going to try 10 new foods and these 10 new dinners, and by you getting those 10 X's for those 2 things and for 10 things and for trying them, you get whatever that might be, a new Xbox game or whatever the reward is. If you set up a system where you're rewarding not only with praise but also with something else, if you need something else to motivate him, but you really want to apply the same techniques and the same approach for any of us, because these are techniques that work for us even as adults.
Okay. My child will only eat when he's allowed to see videos. I have tried and tried. What are some of the strategies you've used to get kids with that habit to stop?
That's a really good question. We do see it a lot. To be able to answer that fully accurately, I would need to see the motivating factors for your child and what set that up. So if you have an ABA therapist involved, or if you have an occupational therapist involved, getting those eyes on it and seeing that picture of what's driving that choice would be helpful in helping you create a solution. In the past, with other families that we've worked with, we've created a number of different reward and incentive programs depending on what was motivating the child. So, okay, you have to take the bite before we turn the video on. Okay, you get 10 seconds of the video, now you have to take another bite, and then gradually fading. Some type or something that looks somewhat like that has worked in the past, but I would really need more info to, I think, be more helpful to you. I'm sorry.
Okay, where can I find a nutritionist in my area who's trained to work specifically with children with autism? Is there a list, or is there a list of questions I could ask?
If you contact us here, I can help you with that. I think, Denise, ARI also makes regional referrals for support on occasion. Am I wrong in thinking that?
Typically, we refer people to their support groups in their area. That's usually how we do it.
Okay. I'm happy to help people locate professionals that we know, or you can go that route as well in terms of networking with a local support group.
Okay. What about supplements? If they won't eat foods, do supplements do the job?
Ultimately, no. Supplements can be a nice bridge to making a difference in a child's nutritional status, but ultimately, we don't know enough about the science of our food to know what we're missing out on when we take a multivitamin. We certainly know we're not getting enough fiber, and by not getting enough fiber, we need fat. You know, there are all these things that, from an interplay perspective, need to be components of our diet, so supplements alone won't do the job.
This year, our pediatrician became concerned about slow weight gain, sensory issues, and history of reflux. I've been concerned about engaging in struggles or focus on food because I know that girls are at risk for developing eating disorders. We are trying to model great eating, but we are very picky eaters as well. What are some strategies that we can use as a family to change together?
I think if you think about those checklists and tools and techniques that I listed, and engaging and wrapping around and holding each of you to the same standard, so that whatever that standard is, and you each need to define that for your family, we're going to go by vegetables this week, and we're going to make 2 salads, and they're going to contain 2 different ingredients that we've never tried before, and then everyone is involved in choosing and purchasing and preparing and eating. That seems, both from a clinical perspective and also a research perspective, to make the most change in families as a unit, because you are doing what you said, and that is modeling behavior that could change your eating patterns as well as your child's.